content later, that would be great. Okay, wonderful. So thanks everyone for joining, and good morning or good afternoon, depending on where you are. This is our second session in the PrEP Learning Network, hosted by Options, Epic, and RISE. And I said this at the beginning, but if you are logging in for our webinar today, you should have the ability to mute and unmute yourself. So please mute yourselves when you're listening in on the presentation so we can limit that background noise, but definitely unmute yourselves during the question and answer portion, as we want this to be a learning network and we want you all to learn from each other and jump in and ask questions and provide shared experiences and stories with others. So please feel free to unmute yourselves during that Q&A, but keep yourselves on mute to limit the background noise, since there are lots of us on the line today. So we want to make sure we hear these great presentations. So we're going to go ahead and jump right in. So as I mentioned, this is our second session of the PrEP Learning Network, and really there's two goals of the PrEP Learning Network. One is to create a forum to share PrEP scale-up experiences, resources, research with each other. And the second, the larger goal, is to support the epidemic control by helping countries achieve PrEP targets, really by sharing these stories and resources and research with each other. So again, this is the Learning Network, so please feel free to jump in with questions and stories during that Q&A portion. Our first session last month was great. We had lots of attendees and 3 wonderful implementing partners that were discussing their PrEP scale-up journeys. And during that session, a lot of questions kept coming up around continuation. So questions around what are the main reasons for PrEP discontinuation? What's the average length of stay on PrEP by population? How do you ensure PrEP clients stay on PrEP? So these questions kept coming up, and so we're excited today to have a fully dedicated session on the topic of PrEP continuation. And so our speakers today are really representing a range of perspectives. We have Jessica Rodriguez, who is the Prevention Market Manager and with AVAC. We have Gwen Chapania, who is with SHAZ Hub and PZAT from Zimbabwe, Daniel Ware from Jhpiego, Jilinde in Kenya, and Jason Reed from Jhpiego. And they'll really be discussing different perspectives. So Gwen and Daniel will be sharing their experiences as implementing partners around PrEP continuation challenges, effective strategies, and lessons learned. And we'll hear from Jason and Jessica on recent findings from a think tank on defining and measuring PrEP success and effective use. So really getting lots of different perspectives today on the topic of PrEP continuation. So if you're new to Zoom, I just wanted to take a quick minute to let you know where the chat feature is. So there should be a black bar across the top or bottom of your screen. You'll click on that little speech bubble that says chat so you can open the chat section. And so during our first session in August, our chat was really active and engaged. So please feel free to continue to use that chat and jump in with questions during the presentations via chat. But also please feel free to unmute yourselves using *6 on your phones when we get to that Q&A portion, so that we can share stories and engage with each other as well. Okay, and so with that, we have a really full agenda. So I'm going to kick it to Jessica Rodriguez to introduce the importance of PrEP continuation of our topic today. So Jessica, I'll hand it to you.
Hi, Sam. Thank you so much. I'm Jessica Rodriguez, the Director of Product Introduction and Access at AVAC, and I'm very excited to be here with all of you today. And I wanted to provide a few framing slides to anchor our discussion. As we all have observed, and many of the data and evidence has shown, starting PrEP is easier than staying on PrEP. Many projects have shown data and evidence that there are high rates of initiation, but a significant proportion of PrEP adopters do not return for their first refill or are delayed in doing so. And this may be intentional because they no longer feel at risk, or the individual couldn't return to the health facility. They may be discouraged by the quality of care they received and feel judged by providers. So there could be multiple reasons why someone may discontinue PrEP or stop and restart. And this slide here really shows that more than half of adolescent girls and young women who started PrEP in the Power Project stopped taking PrEP after 1 month. So high rates of discontinuation. And this is not unique to any one project. It's a common trend that's been observed among many projects and many populations, especially when PrEP implementation is nascent. So there's been a significant focus on outreach and scale up as PrEP moved from pilots and demonstration projects to programs. And this also has resulted in a focus on meeting initiation targets. And we all know what gets measured, gets funded, and gets done. And I also wanted to mention that part of the challenge we face is that the parameters for ART retention have largely influenced the definition of success for oral PrEP use, where consecutive and continuous days of use are the metric by which we have defined success for PrEP use. However, I also wanted to draw inspiration and mention that PrEP scale-up experience in the US, the UK, and Australia shows that refill patterns normalize with time, and that over time, as PrEP coverage increases, there have been observed decreases in HIV incidence, of course, combined with universal test and treat. So essentially, this next slide illustrates that. This is a graph that was published in a report released by AMFOR, AVAC, and Friends of the Global Fight, Translation of Progress into Success to End the AIDS Epidemic. And this shows that in San Francisco, after PrEP was introduced, there was a significant decline in HIV incidence. So I think there is inspiration to draw from these examples, because as PrEP programs mature, there is some evidence that refill patterns will normalize. So essentially, this requires a paradigm shift in how continuation is defined and measured in the context of oral PrEP delivery. So as we know, since risk varies, so can use. There are seasons of risk vary for individuals, and use does not have to be continuous to be effective as long as it covers an individual's risk period. So through the think tank, we have kind of identified 3 patterns of PrEP use. Continuous, which is a start followed by use for a number of consecutive days. And that can be 30, 90, 80, 180, whatever is defined by a certain indicator. So this is really more synonymous with ART retention. Use can be episodic, which is a start followed by use to cover an individual's risk period, followed by stop and restart cycles. Then there is also event-driven PrEP, or 211, which is a loading dose start followed by 2 days of use. So regardless, as long as use covers the risk period, all of these patterns are effective. And so given these definitions and parameters, in the think tank, which was co-convened by Jhpiego and the Prevention Market Manager, which is funded by the Bill and Melinda Gates Foundation, and with technical support from USAID, we gathered with different implementers, researchers, methodologists from who have significant experience and expertise in PrEP delivery, as well as experts from other fields who could lend their knowledge and ideas to coming up with new parameters and definitions for success. And so later on in the webinar, we will explore what we discussed and the findings from the think tank, and really dig into how this then relates to measurement. So with this framing, I will hand it over to Sam so that we can head into the country examples and presentations of how to really address and respond to supporting PrEP adopters to continue on PrEP.
Perfect. Thanks so much, Jessica. Great and super helpful overview of just framing the importance of this conversation in terms of the challenges that PrEP continuation can really create, and then also the differences in terms of how we're defining effective use with PrEP versus ART. So as Jessica mentioned, her and Jason Reed from Jhpiego will be back on later in the webinar to further discuss findings from a think tank in terms of how they're defining effective use and how thinking about that differently, and have some great questions for all of you to engage in a little bit more. But with that framing, we're going to pass it to Daniel Ware, who's the project director of Jilinde in Kenya, to discuss how they applied a behavioral economics approach to their PrEP continuation challenges. So I'm going to pass it to Daniel.
Yeah, so thank you, Samantha, and really it's an honor and a pleasure for us to share some of our experiences around PrEP implementation in Kenya through the Jilinde project, which essentially we define as a learning laboratory. Next slide. So a quick summary of Jilinde and what the project is all about. That essentially Jilinde is a project funded by the Bill and Melinda Gates Foundation, and the overall intention for this project is essentially to implement PrEP in routine service delivery settings with an end goal of demonstrating and documenting a model to really show and build evidence on really how best to scale up PrEP in low resource settings. Next slide. So this project is implemented in 10 out of the 47 counties of Kenya. The three primary target populations for this project is female sex workers, men who have sex with men, and adolescent girls and young women. But it's important just to note that we're implementing PrEP within the auspices of a national PrEP program, where PrEP is offered to anybody who is eligible and who requests for it. So in that sense, we also have serodiscordant couples and individuals from the general population who are also benefiting from PrEP through sites supported by this project. And overall, through the 4-year duration of this project, the target was actually to initiate 20,776 individuals on PrEP as a demonstration really of whether PrEP uptake can work at scale. Next slide. So just for a quick introduction of what behavioral economics is, a very quick summary, I would simply say that behavioral economics blends insights from psychology and economics with a keen intention of really trying to understand human behaviors and attitudes, but most especially how people make choices. And the underlying principle in behavioral economics is really that a number of times the choices that people make and human behaviors tends to be non-rational. But if you're able to apply behavioral economics principles, then you can be able to predict and build patterns to help you understand at what points and what are the levers that essentially drive people to make these non-rational choices. And therefore, it is possible actually to position interventions at those critical time points to be able to turn around things. And if you just look at an example of the images in that slide, it tells you just a critical, an example of how behavioral economics actually works. Next slide. So initially, at the first 2 years of this project, that is 2016 and 2017, we used behavioral economics research to help inform segmentation, market segmentation for the target populations that we wanted to reach out. And this slide is just actually an example of the 4 population segments that we did develop for men who have sex with men. And this is what guided a lot of our demand creation to initially support PrEP uptake. Next slide. So if you look at this next slide, I think there's a slide before that. Yeah, so if you look at this next slide, essentially it shows the overall performance of this project as far as PrEP uptake is concerned. And a lot of these achievements, because you can see by end of year 3, which is essentially just by June of 2019, just a few months ago, we had actually already surpassed the 4-year targets for this project. And a lot of this uptake is driven by how we were able to apply the segmentation, ensuring there was more targeted demand creation, and we were able to actually reach out to the different population segments with more targeted demand creation. Next slide. So just to give context around continuation, and the most important thing to note is from our experience implementing the Jilinde project, we realized that estimation of continuation largely depends around what data source one is using and what method of analysis you're using. So as we began this project, we largely used what I'm calling aggregate data. Aggregate data because there are basically 2 data sources at the health facility level where PrEP is provided. We have a daily activity register, which essentially captures a few variables that are critical for all clients who come to the site. And on a monthly basis, that data is actually summarized into what we refer to as a PrEP summary tool, which essentially demonstrates the performance of each individual site. And for the first 2 years of this project, largely the first year of the project, we largely worked with this aggregate data that was available from the sites. And I think one limitation of aggregate data is that it consolidates all the information because it uses a cross-sectional approach to estimate continuation. And the limitation with that is essentially that it likely overestimates continuation. But beginning from year 2 of the project, we were able to access client-level data. And client-level data, the source document is actually what we call a client encounter form. And this is data that is gathered by the clinician actually as they are seeing and prescribing and counseling a client who essentially is eligible to take PrEP. So with access to this data from the second year of the project, what we did as Jilinde essentially was to translate this client encounter form into an Android-based application that is running on a tablet. And this data is actually relayed into a server. And essentially, we're able to access this data from that server, and using an algorithm that we have developed, then we are able actually to do our analysis, longitudinal analysis to be more precise, where we are able to estimate continuation. So of course, the limitation with using this client-level data is the possibility that you're likely to underestimate continuation. But we think this approach actually gives us the best estimate as far as continuation is concerned. Next slide. So this slide is just a comparison of a side-by-side comparison of using aggregate data versus client-level data. And you can see in red, actually, that is the aggregate data, which, as I earlier indicated, likely overestimates the month 1 continuation. And as you can see in blue, that is the actually the client-level data. And this data is defined by what I'm calling a PrEP use cycle. And a PrEP use cycle is essentially a moment when the client used PrEP continuously. What we have experienced is that clients start and stop PrEP use. So essentially, it's likely that one client is likely to have multiple PrEP use cycles. Next slide. So this next slide, again, is just the same comparison of the month 3 continuation rates. And you can still see the differences between aggregate and client level data. Next slide. Much as the previous slides have shown slightly lower continuation rates, I think the most important point I wanted to make from this slide is that continuation actually varies by site and by population type. And this is an example of an outlier site. I would just urge you to ignore the bars because the bars are the clients initiated. But if you look at the trend lines, essentially it shows you both the month 1 and month 3 continuation rates. And this is data from actually 2 drop-in centers serving largely key populations. Next slide. So in the course of implementing these projects, we have embedded and nested within the projects and implementation science agenda to help us understand why actually people start and stop PrEP use. And this is just some of the reasons gathered from self-report from clients using what we are calling a client feedback tool that is given to clients at the end of receiving services. And overriding reason for continued PrEP use, you can see, is actually the need for protection. But of course, the fact that clients are also deriving confidence, and when they receive adequate information, they feel motivated. But reasons for discontinuation include change in risk or change in preferred prevention method, side effects, pill burden, as well as the experience when they visit the clinic. Next slide. So besides that, we have also conducted focus group discussions, which we do routinely, to get a deeper understanding of some of the challenges around continuation. And these range from personal issues around stigma, and the fact that for some individuals within relationships, when their partner is not supportive of PrEP, it likely brings conflicts. There are issues around ambivalence and motivation. There are system level barriers around access, and also providers acting as barriers to PrEP use. And then, of course, there are social cultural issues, largely myths and misconceptions, as well as stigma, and also product challenges, largely around branding and packaging, which has been noted to be unappealing. Next slide. So as a project, one of the things that we have done is to try and implement a number of strategies to improve continuation, which have been implemented both at facility and community level. And I think you'll be able to access the slides. You should be able to actually gather most of that information. Next slide. So what we've done also as a project is using human-centered design. We've been able to dig deeper to gather additional insights to understand why clients are likely to discontinue PrEP use. And the 3 key insights that came out is issues around motivation, issues around choices, and clients wanting to feel special. Next slide. So arising from these insights, we've been able to try and craft additional interventions to understand continuation. Next slide. Just go to the next slide again. And part of what we have gathered even from implementing these interventions is that essentially, while, for example, looking at the routine program data, we have been able to gather some insights around why people discontinue PrEP use. That alone is actually insufficient to give us objective conclusions on actual barriers. The research that we have done, both qualitative and quantitative, has given us, of course, additional insights, including the human-centered design work around some of the behavioral barriers. But what we feel as a project, and this is a work in progress, is essentially the need to use behavioral economics for a deeper understanding of the non-rational barriers to PrEP use. So this is work that is currently in progress, and what we are doing with behavioral economics, one is actually quantitative segmentation, which is helping us to understand the predictors of both persistence and dropout. So this is research that is actually ongoing right now, and it's actually complemented by discrete choice experiments to help us understand more deeply how do clients position PrEP within their lives, and how that influences their choices on whether to actually persist or drop out of PrEP use. So this will be followed by actually qualitative research within the segment-specific, to understand the segment-specific barriers, because out of the quantitative segmentation, we look forward to actually arriving at the predictors for the 3 key segments. One is for people who drop out early, 2 for people who stay for a short while, less than 3 months and drop out, and 3 for those who stay on PrEP for more than 3 months. And out of that, we hope to be able to design interventions, test, and actually scale up. Next slide. So this slide is just showing actually the progress and the timeline for what I've just summarized in the prior slide. And actually at this point in time, we're actually doing the segmentation analysis and discrete choice experiments. Next slide. So just as a near conclusion, I think what I wanted to mention is that one of the key emerging questions that while continuous PrEP use may actually be one of the best goals as we discuss continuation, there are also clients who probably are using PrEP episodically. And this could also be partly because their risks are actually infrequent. And data we have generated from the project is showing us that episodic PrEP use is actually common. And what we've done is actually we are conducting a prospective cohort study to really gather in-depth explanations around the different patterns of PrEP use across the different population groups. So essentially 28% of actually clients initiated on PrEP through the project have actually more than one PrEP use episode. Last slide. So, and this last slide is just to acknowledge the individuals who are partly responsible or fully responsible for the work that are presented in these slides. Thank you.
Great. Thanks so much, Daniel. We had one question come through in the chat, so I'll ask this question, and then others, please feel free to unmute yourselves via Zoom or press *6 if you have other questions. So Barbara asked, can you say a little more about the providers being barriers? Are they barriers because of who they think should get PrEP, or is it more about providers being overworked and not having sufficient time for counseling and support?
So I think a lot of what we have gathered around providers being barrier is on both ends. Number one, of course, there are cases where we've seen clients telling us that they're actually stigmatized because they're PrEP clients. When they go to a facility and they identify as being PrEP clients, probably coming back for a refill, providers will tell them, wait first, I finish my other normal workload before I can attend to you. But there have also been cases, particularly among adolescent girls and young women, who are actually being discouraged from PrEP use by providers because they'll present themselves to the provider, and the provider is like, you're a young girl, why do you want PrEP? So essentially, it has worked on both sides.
Great, thanks.
Yeah, I can see also there's a question from Teresa around, does episodic use provide effective protection? Essentially, the data that we have gathered so far has indicated there's episodic use, but we are not sure if it is providing effective protection. And the prospective cohort study that I did talk about, what we have done is we have given clients a PrEP diary card, which covers 30 days. And within that, they'll be able to document actually their patterns of risk when they're actually having sex or when they're not having sex. They'll document when they're actually having sex, if they're using any prevention method, and they'll also document if they're using PrEP and on which particular days. So once we get this data from this study, which is actually in progress, we have so far enrolled about 30% of the sample. We will be able to have conclusive answers around that.
Great, thanks, Daniel. Other questions for Daniel? Feel free to unmute yourself using *6 on your phone, or on Zoom, you can use the chat feature. It looks like we've got a question from Joseph.
Hi. Thanks, Daniel, for the presentation. My question is on the targets. I noticed that we have surpassed the targets, but we still have a year to go. So I wanted to ask about how the targets were set and whether it's an issue of the targets, or how the targets were set, or the program is actually performing very well.
Yes, so thanks, Joseph, for that question. Essentially, as I did indicate, the overall objective for the Jilinde project was really around to demonstrate really whether PrEP can work at scale. And the point when we started this project is when we were just moving from demonstration projects. So how we set our targets for this project, it was largely, I would say we made lots of assumptions, looking at existing data at that point in time on hypothetically what proportion of clients we thought would actually benefit from PrEP. And that is like for key populations, we set those targets looking at the national estimates, looking at uptake of existing HIV prevention services then, and made a number of assumptions behind that. For adolescent girls and young women, you realize the target was only just 2,000, and that was more or less, let me say, a hypothetical figure we just chose to really see whether there will be any interest and uptake among that particular population. So, but I think I want to mention what is important is that this project was not so much target driven. The essence was more about generating lessons rather than meeting targets. So the target of 20,776 was supposed to be a demonstration of really whether there is uptake of PrEP or whether there is interest.
Hello, can anyone hear me?
Yes, we can.
Yes, we can.
Yeah, I can hear you.
Okay, great. I couldn't hear anything else. Sam, are you there?
Hey, Katie, this is Teresa. I hear you, but I don't hear the speakers.
Okay, no, me either. Sam, I think, are you on mute? Okay.
Oh, here we go. Sorry about that. I'm not sure what happened. Can you hear me now?
Yes, thank you. Okay.
Oh, wonderful. Great. Okay. Sorry, everyone. We were just thanking Daniel and passing it to Gwen, but I was on mute. So we'll pass it to Gwen now. Gwen, can you hear us?
Thank you, everyone. I hope you're all well. My name is Jilinde. I work with Panjia Zimbabwe AIDS Trust at the Shaping the Health of Adolescents in Zimbabwe Youth Drop-In Center. Next slide, please. I'm just going to give you a brief background to how we then came up with the drop-in center. So the Hub Drop-in Center is a center that's situated in Chitungwiza, that's in Zimbabwe, and it's located within a private hospital, which is supported by our Ministry of Health and Childcare. It began in 2003, where it was a research site. And what we're basically doing was conducting HIV prevention and treatment studies among adolescent girls and young women. And we collected a lot of useful data. And when the research is ended, that's about in 2014, and using lessons learned from the researches that we had done, it then evolved into a youth drop-in center, because a lot of young people had raised concerns that they didn't have places or safe spaces where they could actually go and access health services. Most of them didn't want to go to the public health facilities because they were stigmatized, they were discriminated, and most of the healthcare worker attitudes were not really what they wanted. And so Panjia Zimbabwe AIDS Trust then opened up a youth drop-in center where we are offering comprehensive sexual health and HIV services to approximately 1,400 young people aged between 16 to 24 every year. Next slide, please. So this is just generally the services that we're offering at the SHAZ Hub. I won't go into all of them, but we have health services where we are looking at STI screening and treatment, HIV testing. Then for those who test positive, we are linking them into care and treatment. For those that are negative, we are linking them to comprehensive prevention services, including PrEP. We also have peer support. We are doing pregnancy testing and contraception. And then we're also providing non-clinical services like life skills training, sexuality education, and vocational training skills courses. And these are just short courses which we're providing to the young people on how to make floor wax, toilet cleaner, cordials, and candle making. And then once they finish the skills training, they go through a financial literacy training where we're just teaching them about budgeting and costing, how to start up a business, and it also entails how to register a business if they want to. And then whilst we wanted them to also learn, we then found out that a lot of young people these days are into a lot of Wi-Fi and internet, and we decided to provide these services so that if they wanted to go on the internet and surf any educational material or to gain any knowledge, they would be able to do that using the internet. Next slide, please. Right, so I'll talk about the PrEP delivery at the SHAZ Hub. So we're still in our infancy. We started delivering oral PrEP in January 2018. Initially, it was a collaboration with PSI, that's Population Services International. And because at the time we didn't have the drug, but what we would do is to mobilize young people, and then PSI would come in with the drug. And then in May 2018, we then got support from Gilead, and we were able to hire more staff. So we now have a nurse and 2 peer educators, and we've managed to expand our coverage. Our target population is still 16 to 24 years, and our populations vary. We're looking at adolescent girls and young women. Within that, we have the sex workers, MSM, and transgender populations. And then we then also, in collaboration with the Ministry of Health, we came up with tools, which some of them are on the slide that's there. And we also are using the reporting mechanism through our Ministry of Health. Next slide, please. So I think I'll just give you our adolescent girls and young women continuing rates. If we look at the chart there, we have screened, we have quite high numbers of young girls who were screened. But then when we go to our initiation rates, you find that the numbers then go down. In blue, you find that this is 18%. And we have 32%. So the 18% is the high-risk females, and these are young girls who have multiple sexual partners. And then we have the female sex workers. Those are the sex workers, of course. And then at month 1, we had for our high-risk females, 100%. They came back. And our female sex workers, we had 97%. At 3 months, again, we had 83% for our high-risk females and 70% for our sex workers. At 6 months, for our high-risk females, we're at 100%, and our sex workers were at 63%. And I think I'll talk more as we go on. Next slide, please. I think one of the great successes that we've had at the Hub is our intensive and strategically timed follow-up. On the screen there is our flow chart that we use in identification of the adolescents and any other person who we may deem as eligible to be on PrEP. But specifically in this instance, I'll talk about the adolescent girls. I'm not going to really focus on the flow chart per se, but I think what I'll talk about is our follow-up, because I feel like our follow-up has been really a success story in having high continuation rates. So our follow-up started day 2 after initiation. And just generally, this is done via WhatsApp or a telephone call or a home visit, where we are basically checking to see if the young adolescent has started taking their PrEP. And if they have, we also ask them how they're doing, and if they've managed to disclose to anyone that they're taking PrEP. And then we also have day 5 follow-up. And at day 5, we're basically checking up of if they've experienced any side effects, if they've disclosed to anyone as well that they're taking PrEP, and just general well-being. And then we also have follow-up at day 14, where we are also again checking up on just their general well-being, if they've also disclosed to anyone, because I think for us, disclosure is very important, because the young people will then get support from whoever they'll be staying with. And then again, we also have follow-ups at day 28, where we are basically reminding them to come for their next visit. And then after day 28, we are conducting a 3-month follow-up, but within, again, the 3 months, we're also trying to reach out to them and asking them if they're facing any challenges. If they do face any challenges, it's either we do a home visit or we ask them to come to the clinic, and then we discuss about their challenges and map a way forward, just basically to make them feel supported by the program. Next slide, please. So I'm going to talk about the enabling environment, which has led to high continuation rates. And I think the first one is that initially what we decided was that, yes, you know, it's good to have targets, it's good to have high initiation rates, but we wanted to come up with a model which was slightly different, where we are using a readiness assessment tool to identify and select youth who are not only at risk, but who are interested and to take PrEP. So basically, the risk assessment tool has question on risk perception, commitment to adherence. We are also checking if they are using any other combination prevention methods, and we are also assessing and addressing misconceptions around PrEP, and also their fears, just to find out from the young person if they have any fears, and to just allay them and make them feel supported. And then we also have the regular follow-ups and interactions with the peer mobilizers, which is done by text, call, and home visits. And what we've done with our clients is to say to them, if, for example, you don't have airtime to call, you can actually send a call back. And immediately when we get a call back, we then call them and just find out what their particular need is. And I think our youth-friendly staff as well, all of our staff has been trained in delivering adolescent-friendly services. And I must say that's been a great attributory factor to our high continuation rates as well. And youth-friendly and confidential environment when accessing other services. Like I alluded to initially when I started, where we're talking about the public health setting, it's more open, whereas our environment is discreet, and the young person actually feels welcome and feels safe within our spaces. And then we also have supportive environments which enable the clients, the staff, and the parents and guardians as well to work together to support continuation. So what we also do with the young people during our assessments is to ask if they disclosed to anyone, if they're facing any challenges with disclosure, then we're also there to assist them and support them as well. So that's, we actually have that relationship between the client and the parents at home as well, and with some of their partners as well. So I think that's been a great factor in terms of the enabling environment. Next slide, please. Here's the case story. I'm not going to go through the whole case story, but I'll give you, this is Nikki. She's 21. She's in a relationship with a taxi driver who's 38 years old. Both of them have been treated for an STI, and we met her during one of our outreach sessions, and we managed to talk to her. And she went through a pre-screening process. And I think after the pre-screening process, she then realized that she was at high risk, and we invited her to come to the hub. She then came to the hub, and the nurses then talked to her, explained to her, and then also went through the readiness assessment tool. She then was initiated on PrEP. Next slide, please. And during the discussions, when we talked about disclosure issues, we were asking her if she'd be comfortable disclosing to her partner, and she had said no, not yet, because I think if he finds out that I'm taking PrEP, he's going to beat me up. She also had her fears. So what we then did was we initiated on PrEP, and she went back home. She hid her pills. And one of the days, the partner then got to see the pills, and a flyer that we had given her. He went through the flyer, and then he beat her up. But then she then called us and told us about her story, and we asked her if she would want us to intervene, and she said yes. And we spoke to the partner and told him about the services that we're offering, asked him to come to the clinic, and fortunately, he did come to the clinic, and we talked to him and explained why she was taking PrEP and the benefits of taking PrEP to both of them. And then from that time, I must say, it was one of our best success stories, because the partner ended up understanding. And to this day, the partner is very supportive. He comes with her to the clinic. If he has any questions, he comes to the clinic, or he gives us a call to ask. And I think for us, this is one of the many case stories that we've managed to identify with our young people in terms of the support and the enabling environment that they're getting at the hub. Next slide, please. Right, so I'm going to talk about the challenges that we've been facing in increasing continuation. And the first one is mobility. I think because these are adolescent girls and young women, they are highly mobile. Most of them don't stay with their parents, or for example, the sex workers. So there's really a lot of movement that happens. But what we've done with them is that we encourage them that if they know that they're going to a particular place, then they come to the clinic and notify us, and then they can get a 3-month supply. Or alternatively, if, for example, they're going to a place where a facility is offering PrEP, then we link them to the particular facility so that they can get their refill. Then we've also had a few challenges with adherence because of the size of the pill, where they're complaining that the pill is too big and so forth. And then we've also had 2 cases of intimate partner violence, where a partner then finds out that they're on PrEP, and then they end up beating them. For one case, we were able to link her into one of our police stations where they have a victim-friendly unit, and the partner was then asked to come to the police station, and then they were cancelled, and then he was warned. So those are just the 2 cases that we've had. We've also had one case of one person who opted out because the parent disapproved or was being unsupportive. So when they found out that their child was on PrEP, they actually took the pills and flushed them in the toilet and told them that they don't want them to be on PrEP. And then another challenge that we've also witnessed is negative cultural perceptions around sex and youth from family, church, and community. I think basically in our culture, sex is for married people. But again, young people are sexually active. And because of that culture, there's a lot of secrecy that's happening where young people are having sex and they don't want to be found out and so forth. So then it becomes a problem when you're staying with your parents to actually take PrEP continuously. So I must say those were the challenges that we've been facing. Last slide, please. So I think the last slide is to acknowledge everyone who took part in the case study. Yeah, thank you very much. And if there are any questions.
Thanks so much, Gwen. And we've had a couple of questions come through, so we're going to unmute a couple of people who submitted. Simon and Beatrice, we saw that you both had questions, so feel free to jump in now. You should be unmuted and ask your questions.
Okay.
Yeah, thank you. Thanks for the presentation. My question was about PrEP continuation among adolescent girls and young women in school versus not in school, those not in school. Are there any variations? And also, what is your experience with in PrEP continuation among those in boarding schools versus those in day schools? Thank you.
Unfortunately, we haven't been able to do that analysis. I think it's something that we'll take into consideration and just do some kind of analysis to find out the different rates. But thank you for that.
All right, thank you.
Great, thanks. We've got a few other hands raised. Beatrice and Mwangwa. Laura, if you want to unmute them, or Beatrice and Mwangwa, you can unmute yourselves using *6 and jump in and ask your questions. Or feel free to use the chat. And we've got a few questions coming in around calculating continuation rates and defining PrEP continuation success by the proportion of people who stop PrEP on their own. So Jason and Jessica will actually be talking a little bit more about defining success, and we'll have Nicole from Avenir Health talk a little bit about calculating continuation rates. So Mika and Chris, we will get to those questions in a few minutes. And Beatrice, I see that you're unmuted. Feel free to jump in. Beatrice, feel free to jump in if you have a question. Otherwise, any other questions for Gwen? Can *6 to unmute yourselves or use the chat. Otherwise, we will move on to our next presentation for now. Okay, great. Gwen, thanks so much. We are going to keep moving, but Gwen will still be on the line until the end of the presentation. So as questions come in, please feel free to use the chat and unmute yourselves during our last Q&A as well. So we're going to move to defining and measuring effective PrEP use and impact with Jason Reed and Jessica Rodriguez. I'll pass it to both of you.
Great, thanks, Sam. Can you hear me okay?
Perfectly.
Great. So this is Jason Reed from Jhpiego, and as Sam mentioned, I had the pleasure of co-hosting along with Jessica, who was on the webinar earlier, and also with Robin Equal from USAID a think tank on PrEP continuation. It's actually the first in a series of think tanks looking at the challenges and hopefully solutions with continuation issues with PrEP. And the first one was devoted solely to defining what successful or effective PrEP use is or should be, and then also about how to measure for effective PrEP use. And we touched a little bit in the first think tank also on measuring impact or forecasting impact. So I'll walk you through a few slides just summarizing some things from the think tank, and then Jessica is also on the line as well still, so can jump in at any time. Next slide. So just to reorient, as Jessica mentioned, it's the experience of many programs, not all, but most, that starting PrEP is perhaps easier than might have been thought, but remaining on PrEP is more challenging. And so Jessica shared some data from different programs. There was actually some data shared yesterday in South Africa by Connie Callum from a South Africa project of PrEP for AGYW that also found these high rates of discontinuation among AGYW, but pretty much across the board, it's high rates of discontinuation, meaning people who fail to return for their first refill or do so, but do so late. It's a universal experience across all of the populations. Probably serodiscordant couples being the one exception, and most programs have better rates of continuation. But other than that, most of the other populations experience these high rates of early stop or delay. Next slide. And also, as Jessica mentioned, there's no single regimen of PrEP use that suits all people optimally. And she reviewed at least 3 patterns of PrEP use that are being observed by PrEP programs. Continuous use, which is sort of analogous to ART retention, in which somebody starts PrEP and then just continues it indefinitely. Episodic use, where the person takes it for the duration sufficient to cover their period of risk and then stops and restarts later, or event-driven PrEP, specifically for MSM and transgender women that WHO recently recommended. That's the 2-1-1 loading dose and 2 days of PrEP after risk. And Jessica rightly noted that all of these are effective. And I think the challenge that many people are facing, and the reason that the think tank was convened, is because the current indicators really only measure for the first, continuous use. And this was largely drawn from the M&E approaches from ART programs, where once somebody starts PrEP, the intention is to indefinitely take it forevermore. And so that was pretty much adopted. That type of approach was adopted by donors and normative agencies to also look at PrEP continuation. And so the challenge we have is that because people are using episodically or event-driven, the current M&E approaches don't account for those types of use. Next slide. So because there's no single definition of effective use, not surprisingly, there's also no single measure. And so in the think tank, we brought together about 25 stakeholders, mostly implementers, but also methodologists, modelers, biostatistician from Gilead. It's a variety of stakeholders to come for a day or 2 days to contemplate sort of this issue about multiple definitions of success and multiple measures. And so the implementers in particular shared their experience with monitoring their programs. And so we've summarized those on the next slide. Largely, these measurements fell into 2 categories: cross-sectional and longitudinal. And they're listed out here, and you can see them. I don't think any of these will surprise anyone. The cross-sectional measures are largely count measurements, where we're either counting number of people, number of pills, or number of visits at a given point in time. For the first, where we count the number of people currently taking PrEP or on PrEP in the reporting period, everybody's really familiar with these, of course, because they're analogous to the PEPFAR indicators, PrEP-NEW and PrEP-CUR. Some programs, in addition to counting the number of people taking or having taken PrEP before, are also counting the volume of PrEP dispensed. And there's just a note here in the comment column that if you combine the volume of PrEP dispensed with the number of people taking PrEP, it is possible to derive a coverage estimate, and that becomes important for reasons I'll mention in a moment. And then some programs are, in addition to counting number of clients or number of pills distributed, are counting a site level measurement for just the number and types of visit that are provided. So not client level data, but saying for a facility at the end of a month or at the end of a quarter that, for instance, 100 PrEP related visits occurred, and that 50 were initiation visits, 30 were routine refills, and 20 were restarts. And so those are just aggregated up and reported for an entire site. And from those, if you do that over a period of time, it's possible to derive aggregate percents of people discontinuing, continuing, and restarting. And then the second set of measures fall under the category of longitudinal measures. You'll see here this is flagged as relatively more difficult because it requires monitoring at the client level, and so pretty much is dependent upon an electronic database. And in these longitudinal systems, though people have different databases that they've been using, typically they have in common that they all measure the date of every single PrEP prescription and the volume of PrEP dispensed at every prescription. And then they have a number of variables that they monitor in addition to those. And the comment here is that with the longitudinal measures, it becomes possible to differentiate continuous versus episodic use, to characterize use and non-use durations or patterns of use, and to identify client level or site level or provider level predictors of different use patterns in case a particular site or provider or population has especially erratic use, in case intervention is warranted to improve the program. So just to note that most of the implementers that were at the think tank were not using a single approach, but using some mix of all of these. And so it was a good chance to really share the intricacies of these different approaches. And there will be a full meeting report forthcoming that summarizes all of these in much greater detail. And we'll of course share that with this group. Next slide. I mentioned that the think tank also touched a bit on impact, even though our main focus was on defining and measuring continuation or use of PrEP. So just, it was in the back of everyone's minds and repeatedly revisited throughout the think tank whether or not the M&E methods that were being used were helpful for forecasting impact. Of course, everybody's using the M&E approaches to report to the donor or report to the Ministry of Health for accountability reasons. Many of the implementers are also using their data for program improvement, but a number of the programs are trying to use the M&E data also to inform the mathematical modeling of impact. And so I think the impact modeling that most of us were familiar with required some sort of person time of use. And so we went into the meeting thinking that, largely you would need longitudinal measures to be in place if you were going to try to model impact. But it was interesting because we also had representatives from the field of contraception at the think tank, and they presented an approach for modeling impact that was based solely upon distribution of product. And so without making any assumptions about whether people used or didn't use and for how long they used or for how long they were at risk, they have a measure called CYP, or couple year protection, that estimates the impact of the program solely on the distribution, the volume of the product distributed, and to the number of people it was distributed to. And interestingly, the representative from Gilead also had data from the US specifically that showed that you could, if you had adequate surveillance systems, that you could forecast impact based solely upon distribution of product without making any assumptions about duration of use. So we just were putting that out there for thought that, especially with event-driven PrEP, as monitoring and evaluation of PrEP becomes more and more complicated, perhaps a complementary approach that we should be thinking about is modeling impact based upon volume distributed, in addition to trying to track patterns of use. Next slide. So as I mentioned, there will be a meeting report. Currently, we're circulating the executive summary where we're proposing a number of things for normative agencies and donors to consider. First on that list is that because there's no single measurement, but there is currently only one indicator, that continued cross-sectional measurement, or that cross-sectional measures should continue, and the existing indicators should be retained, but that a subset of programs or sites would collect longitudinal measurements to not only complement or validate the cross-sectional measurements, but as the program is nascent and still in a period of continuous improvement, also do the longitudinal measurements so that we can have client-level predictors of suboptimal use for the purposes of program improvement. We're proposing adding an additional indicator for the PrEP, the volume of PrEP dispensed, for the reasons that I talked about. We're flagging that the current event-driven dosing, the 2-1-1 dosing recently recommended by WHO, none of the existing M&E approaches that were showcased at the think tank were able to account for event-driven dosing. And so that remains an unresolved question. Also proposing intensified monitoring and research to map use and risk patterns. And Daniel Wary, my colleague, talked about the longitudinal cohort in Kenya that will be doing that with a diary card and survey. And then finally, just a note of caution that until the set of indicators are rounded out to account for episodic and event-driven dosing, that the single indicator that is currently being used, which is percent continuation at any given month, that if those rates are low, that should be interpreted cautiously, because just because somebody does not come for 3 consecutive months of refills doesn't mean that they're not using the PrEP that they have in an effective way. So I'll stop there. I know Jessica's on the line in case she has anything to add, and if not, I think also I'm gonna hand over next to Nicole Bellows from Avenir Health to walk us through the PrEP tool that's gonna also address some of these continuation issues.
Wonderful. Thanks, Jason. And Jessica, please feel free to chime in. I saw you added some additional context in the chat, so I wanted to give you this chance to add other thoughts and context from the study.
Thank you, Sam. I'll do so briefly because I know that we're waiting for Nicole to present, and I think Jason really summarized the highlights from the think tank very eloquently. So, but I did want to add that I think it's important to really distill and distinguish between how do we invest in effective approaches to support PrEP adopters to stay on PrEP, and to address some of the challenges that might be associated with service delivery and really providing better quality of care. And then what can we do to address some of the challenges with the commonly used definitions and measurements. And so I just wanted to call out those distinctions, and that we have, calling out for a need to do both simultaneously, and it's not one or the other, and they're not mutually exclusive. So I wanted to call that out, and also to mention that this think tank really built on a small meeting that was held on the sidelines of R4P in 2018, where a small group of PrEP researchers and implementers gathered to discuss continuation challenges. So I did want to mention that and kind of say that this think tank is a series that built on that initial meeting and will continue. And I know that some of the participants in the think tank are on the line, so also happy as we move into the Q&A to hear from them and hear their thoughts and comments. Thank you.
Perfect. Thanks so much, Jessica. I'm going to pitch it to Nicole Bellows, who's on the line from Avenir Health, to talk a little bit about a continuation calculator that's part of the PrEP module. And so there will be a separate webinar exclusively on target setting and measurement in November, but wanted to preview this tool since measuring continuation is very complex, as Jason and Jessica were talking about. So Nicole will walk you through quickly this tool that exists to provide some support in this.
Great, thank you everyone, and thanks to Jason and Jessica as well for an interesting presentation. The PrEP tool is coming out in the 24th of this month, and we're going to have an accompanying webinar, so you can, hopefully people have heard about it, otherwise they can get more information from Options. It's the USA PEPFAR funded by Options, as well as the HP Plus and the EPEP2 project. Does a lot of different things. The most relevant for this webinar is the tracking the PrEP Cascade module, which in addition to tracking monthly initiation data and related metrics, also requires looking at the continuation rates at months 1, 3, 6, and 12 after initiation. And from these, it creates a continuation curve that is really important for the rest of the tool because it influences target setting, cost forecasting, and estimating impact as well. We talked a lot about continuation rates in the development of the tool and said, well, some people already know this and others might be struggling, and how do we kind of accommodate different types of users? And where we landed was that for those who already have their continuation rates or a good estimate of them from existing M&E systems, they can directly enter them. We also provide some reference data from programs that are just starting out and might not know their continuation rates or have good data. And then we also have an optional feature to enter a sample of client level data into what we call our continuation calculator. This was born out of our initial in-country visits where people were saying we could really use some help in figuring out how to calculate continuation rates. We talked around today about a lot of the complexities around that. And I think this is still an evolving field, but what we wanted to do was kind of create something now that could be useful with a minimum amount of data inputs, being cognizant of the administrative burden that both data collection and input requires. So we've created something pretty simple that calculates both continuation rates as well as some other features. This gives you just sort of an overview of the steps. The first step is to sort of specify the reinitiation gap. So how long between somebody has run out of drugs or and they're overdue for their appointment. Do we want to say now we consider it a discontinuation, and anything after that would be a reinitiation? This can really vary between a couple of days versus a longer period, depending on how one wants to specify it. While we recognize that a lot of people don't have are unable to track discontinuation, and a lot of it is lost to follow-up, we do put that in as an optional feature mostly if people are able for a sample to look at, how many are no longer at high risk. These are editable, so someone could kind of customize this list. That's something they're going to do. And then step 3 is to enter client level data, where we have we're up to some data around initiation, such as the ID number, the priority population, if they're tracking discontinuation reasons, and then just the dates of initiation and the days drug supply. So similar to what Jason was talking about, as well as Dan, and tracking those, when did people come and how many drugs they were getting, tracking that over time. So that's sort of the, put in a sample and then you get your results, which will give you, those data points that are important for PrEP in terms of the continuation curve, as well as the percent who are reinitiating PrEP, because that seems to be an important metric people are grappling with as well. And then if the data is available, something around discontinuation and discontinuation reasons. So that's just a real brief overview of this one little feature of PrEP, but hopefully we think it can be helpful for some users.
Great. Thanks so much, Nicole. So we're going to leave the last 10 minutes open here for open Q&A. We heard from Daniel about applying a behavioral economics approach to continuation. We heard from Gwen about PrEP continuation among adolescent girls and young women and some effective strategies and challenges there. And then Jason and Jessica just talked through how to measure effective use, the different definitions, and how to model impact, as well as use this continuation calculator that Nicole just went through. So lots of different topics on continuation. And so we're going to unmute the attendees so that you can all jump in with questions that you might have for any of our great speakers today, or if you just have experiences that you want to share, please feel free to jump in.
That I believe that our ownership, and I think that's something which needs to be given a feedback to them.
Hi, I don't know if you can hear me. This is Maria. I just have a quick question for the last two speakers. I'm wondering how is these ideas of measuring effective use being considered in the calculation of the continuation curve, or how those two are related? Thank you.
This is Nicole. Are you asking about adherence among drugs? Is that, just to clarify?
Yes.
I think from the continuation calculator perspective, we discuss this a lot. We think that if people are coming back and continuing to have continuation visits, that then we are putting in the assumption that they're using the drugs. We don't assume just because somebody received the drugs, if we never see them again, we do not consider that that being used, and so that doesn't count towards the continuation, if that matters. So, talking about sort of the calculations and how they're done specifically. But for our purposes, we at this point, at least, we are kind of assuming that people are adhering if they're continuing to go through the motions of actually getting the drugs in hand. I don't know how others have approached this issue, though.
Yeah, Maria, that's the same. For us, we're using refills as a proxy for actual use. And as Daniel mentioned, with the cohort, we'll be able to better ascertain whether that's a correct assumption or how correct or incorrect that assumption is. But for now, it's refills as the proxy.
This is Jessica. So it also might be interesting, as we have a lot of implementers on the line, to hear from them how they're addressing this issue. So feel free to chime in.
And if you want to chime in, press *6 on your phone. I believe you're all muted now, but you can unmute yourselves if you want to share your experiences in measurement. And while we're waiting on that, we got a question from Beatrice related to adolescent girls and young women. This is directed at Gwen. The percentage of adolescent girls and young women who happen to have phones, it's something that they encountered challenges with in engaging with adolescent girls and young women. So wanted to ask Gwen around phone ownership related to your SHAZ Hub program.
Thank you for that question. Fortunately, with all our clients, they all have phones. We haven't encountered any problems with any who don't have phones. I think in rare cases, you'd find that they may not necessarily, if they don't have a phone, we could do a physical follow-up through the peer educators. But in most instances, they actually do have phones.
Great. Thanks for sharing, Gwen. Other thoughts on adherence, continuation? Jason, feel free to jump in and ask the question that you just asked in the chat as well. We've got some people unmuted, so implementers, please jump in with experiences.
Sure, so I'll relay it over the line. I'm just curious to know if people have first impressions or what their initial impressions might be of going the route of the contraception field and forgoing monitoring of actual use or continuation at all, and simply looking at volume of the product distributed as a measure of the program. We specifically brought in an expert from that field, thinking that a consideration of a couple years protected, that measure, CYP, might be something that would be helpful. I think what we heard from the contraception folks was that they actually struggle a lot with that, with CYP as an indicator, because there are so many assumptions underlying it, and there are so many unanswered questions about actual use when they simply look at volume distributed. But at the same time, I think at the risk of programs being declared, early failures because of low proportions of people returning on time for refills, and especially with the new event-driven dosing for MSM and transgender women, volume distributed may actually be something that is useful for us.
Hi, I wish to contribute to that. I'm Jen. I'm Jen from Jilinde. Hello.
Yes, Jane.
Yeah, I would like to back up what Jason has said. If we were able to come up with a factor that we can multiply to show effectiveness of PrEP, it will be equal measure that everybody will use, instead of every program having their own way of calculating continuation. For Jilinde, what we have is we have the longitudinal, since we have the EMR for all our clients, which is easy to calculate. But when we look at the people who don't have EMR and they're trying to calculate it using paper-based, it is very difficult to estimate what is this continuation looks like for month 1, month 3, and month 4, and month 6. Even when we talk about continuation at month 1, it doesn't mean for real this person took PrEP. So if we have a factor, as we are saying for family planning, when you multiply maybe with the number of pills the client is given a specific period of time, we know this client is protected for a specific time. If we say it's a whole year or a whole month or as 1 week, then it will make all programs, even all the programs across the countries work easy.
Yeah, and oh, sorry. I just wanted to add very quickly, this is Maria again, on measuring effective use, not thinking at the individual, at the client level, when the client comes in, for the person providing counseling and in terms of PrEP adherence, how, what is the measures that they should use in terms of effective use for PrEP? What would you recommend there, or what are colleagues using? I think that'd be very helpful to hear. Thank
you. Great. Thanks for that. Thanks for that exchange, Jane and Maria. Joseph, did you want to chime in on Maria's question, or did you have another question?
Yeah, so I just wanted to contribute to that because I think it's a good proxy for measuring coverage, but when it comes to effective use, there are a number of other things that then come into play. So the first one is risk perception, because we found that even for those that we have initiated on PrEP, it takes a while for them to perceive themselves to be at high risk. And that's tied also then to motivation to initiate and continue on PrEP, but also the issues to do with risk cycles. So we have come across some instances where you dispense, but then the client doesn't start taking PrEP on the day that you dispensed. They have a week or two, or even come back a month down the line when you follow up without having initiated taking the drugs, because they still have some concerns. They're still not seeing themselves to be at risk or motivated enough. So using that as a single measure of effective use has also its limitations, but I think it works well in terms of coverage and also determining levels of interest, but we then need to use that along with other measures to determine effective use.
Great. Thanks so much, Joseph, Jane, and Maria, for those questions. And thanks to all of our speakers, Jason, Jessica, Nicole, Gwen, and Daniel. Really great content and insights on PrEP continuation, which is a very complex topic. I'm going to wrap up here with a reminder that our next session is in 2 weeks on September 26th on demand creation, and focused on developing an insight-driven strategy. So we have great speakers here talking about the importance of using insights to create your demand creation strategy, as well as a deeper dive on using human-centered design. We've got a couple of more sessions in the next couple of months focused on a variety of topics such as demand creation, PrEP integration, and a deeper dive on target setting and costing that Nicole previewed today. We also wanted you to save the date, November 11th to November 13th in Blantyre, Malawi. We are having a face-to-face regional workshop that is focused on PrEP scale-up as well, and so more details to come in the next couple of weeks on that. And as always, you will find the recordings and slides on PrEP Watch, as well as resources that were referenced in today's webinar. So continue to look at that website for upcoming webinars and register for those that are of interest. So we're going to close out. Thanks again, everyone, for participating, and thanks to our speakers. We're going to launch a poll so you can let us know how helpful this content was, and we can continue to improve our content as we move forward. So Laura, you can go ahead and launch that poll if you're able to do that. And with that, we will close out. So thanks, everyone.